Well, good evening and welcome to this Wolper Wellbeing Forum hosted by Wolper Jewish Hospital and Friends of Wolper. And our topic tonight is food intolerances and allergies, diagnosis and management. And my name's Julie McCrossin, and it's my great pleasure to be our host this evening. I'd like to begin by acknowledging that we're broadcasting to you from the land of the Gadigal people in Sydney, and that we pay our respects to elders past and present. And if this is your first time joining us for a Wolper Wellbeing Forum, Wolper Jewish Hospital is a specialist medical rehabilitation and palliative care hospital in the eastern suburbs of Sydney. Wolper welcomes people from all cultural, religious backgrounds while offering care within a framework of Jewish culture, religious values, and dietary requirements. And tonight we'd particularly like to acknowledge the generous donation from the Shell family in memory of their husband and father, Dr. Alan Shell, OAM. Dr. Shell was a long-time supporter of Wolper Jewish Hospital, passionate about health education, and in keeping with this vision, Wolper will be dedicating the donation to the ongoing health education activities, including this wellbeing program. And many of you will remember Alan Shell as a long-term general practitioner, question moderator, and we all miss him. And another message for you, Wolper runs a healthy ageing program called Healthy Mind, Healthy Body, and it's for people over 65 who are working to maintain their health and well-being. This 12-week course includes exercise, brain training, and practical lifestyle advice. And Wolper is going to run 2 Healthy Mind, Healthy Body programs in 2026. So please look out over the next few days for a follow-up email, and there'll be more information there for you. Now, quick housekeeping. Your questions are most welcome throughout this webinar. Just put them in the Q&A. Remember, we cannot see or hear you, so this is the only way that you can ask questions. Our question moderator this evening is Dr. Lena Safro, and she will join us regularly with your questions during the panel. She's monitoring them all, and then she comes onto the screen during the panel discussion and shares your questions. We'll answer as many as we possibly can, but of course we cannot give individual advice. And this webinar is being recorded, so you'll be able to see it shortly on the Wolper Hospital website. Well, before we meet our panel, an opportunity to welcome Grace Canning. Grace is a health and disability advocate and an allergy awareness speaker. Grace lives with multiple allergies herself, and she leads Allergy Life Australia's national programs, including support groups and community safety programs. Welcome to you, Grace, and over to you. Thank you.
Thank you, Julie, and thank you, Wolper Jewish Hospital, for hosting this wellbeing webinar on such an important topic. As mentioned, I'm Grace from Allergy Life Australia, a national charity that supports Australians with allergies. Allergies are amongst the fastest growing chronic health conditions in Australia. So you either have allergies or you know someone who does. Some common food allergies include allergies to peanuts, tree nuts, wheat, milk, dairy, egg, shellfish, fish, sesame, soy, and lupin. As mentioned, I myself have food allergies to cashews, pistachios, shellfish, and sunflower seeds. So if I consume any of the foods that I am allergic to, it causes, for me, anaphylaxis, an allergic reaction, also known as anaphylactic shock or an anaphylactic reaction. If anaphylaxis is not treated immediately, it can and has been fatal. For those that survive anaphylactic events, they have to live with the continued fear, anxiety, trauma, and also the risk that it can happen again. But I'm not the only person who has allergic reactions or has food allergies. Food allergies can impact quality of life through physical health, mental health and well-being, socially, work, productivity, and financially. This impact is not only for the person living with allergies, but also those who care for them. Food allergies are serious and they are challenging. If you have food allergies or care for someone who does, I want you to know that you're not alone. There's a large community out there, and there are organisations like Allergy Life Australia that support you, and there are many people who care about you. And if you don't have food allergies, and you meet someone who does have food allergies, please help them, support them, listen to them, and be understanding. As a national support organisation, Allergy Life Australia runs monthly peer allergy support groups for families with allergies and adults with allergies. We also have the My Allergy Card, which is a mobile app that empowers people to advocate for their allergies so they can reduce risks. These, along with other support initiatives, are all free to access. So if you please visit allergylife.com.au, you can learn more. Thank you for having us come here today to talk with you. And supporting people with allergies is a community effort, and we appreciate everyone who is there for us. So together, if we can make it a safer and happier world for those living with allergies. Thank you, Julie.
Thank you very much, Grace, and thank you for coming on. And later in the course of our discussion, we will be mentioning three other sources of information that we can find on different websites, and the links will all be sent to you with that follow-up email. Did you notice that rather sophisticated way I just had of moving my notes across the screen? But lovely to see you, Grace. Well, now, just before we introduce our panel who are waiting in the wings, we're going to do a quick live poll so they can learn a little bit more about you. So what I will do is I will read each question. We ask you to answer the question on the screen, and then I'll give you the result immediately after. So Nat, our technical whiz behind the scene, if we could start with gender. Your gender, please, male, female, other, or prefer not to say. Thank you. We've got 23% male, 74% female, and 3% other. And age is next. Your age, one choice, please. 39 years old or younger, 40 to 60, 61 to 74, 75 or older. 1% 39 or younger, 12% 40 to 60, 34% 61 to 74, and 52% 75 years or older. And welcome to you all. Now, next is the beginning of general screening and demographics. Do you have a food allergy or a food intolerance? If you could click if you've had such a diagnosis, please. So food allergies, 17%, food intolerance, 38%, not sure, 11%, and neither, 35%. Thank you. Diagnosis. Has your food allergy or food intolerance been diagnosed by a medical professional, for example, an allergist, dietitian, GP? Yes, medically diagnosed, self-diagnosed, not diagnosed. Yes, medically diagnosed, 43%, self-diagnosed, 21%, not diagnosed, 37%. Thank you. Our next one is on symptoms. How severe are your symptoms? Mild, moderate, severe, life-threatening? Mild, 31%, moderate, 44%, severe, 23%, life-threatening, 2%. Thank you. We have two more questions for you. Reactions is next. Reactions. When you have a reaction, what is the typical outcome? Discomfort resolved at home, over-the-counter medication needed, for example, antihistamine, visit to emergency or hospitalisation needed, EpiPen auto-injector required. Discomfort resolved at home, 60%. Over-the-counter medication, 27%. Visit to emergency or hospitalisation needed, 5%. EpiPen auto-injector required, 7%. And we have one last question on management and lifestyle. How confident are you in managing your dietary restrictions in daily life? Just one answer, please. Very confident or confident, somewhat confident, not confident at all. Very confident, 36%. Somewhat confident, 61%. Not confident at all, 4%. Look, thank you so much for that. I think our panel members do find it helpful to learn a little bit about you. So now let's learn a little bit about the panel members. I'd like to welcome onto our screen for this panel discussion on food intolerances and allergies, diagnosis and management. It's welcome to Dr. Anne Swain, a dietitian, head dietitian at the Allergy Unit at Royal Prince Alfred Hospital, where she's been working for over 40 years. Associate Professor Jennifer Koplin, an epidemiologist at the University of Queensland, a scientist and a researcher with a particular focus on childhood allergic disease. And Dr. Lara Ford, a medical doctor, senior staff specialist, pediatric allergy and immunology at the Children's Hospital at Westmead, where she's predominantly seeing people from 0 to 18. And I'll just say a little bit more about you, Dr. Ford, because I'm going to begin with you, and I'll tell you a little bit more, ladies and gentlemen, and everyone, about each person as I bring them on. But Dr. Ford is the clinical lead of the New South Wales Anaphylaxis Education Program, which, along, I think, with the nursing team, is involved in education around anaphylaxis in public schools, and you have both United States and Australian research. And so, welcome. You might pop your microphone on at this time. But just start with this really clear question. What is a food allergy, and what is a food intolerance, and what is the significant difference that we need to understand? Welcome.
Hi, thanks. It's really nice to be here, Julie. Um, so a food allergy is in its the sense that people most commonly mean, it's an immediate type allergic reaction that happens within minutes of eating the culprit food. It's reproducible, meaning it happens every time you eat the food, not intermittently. And it can cause symptoms ranging from mild symptoms like skin symptoms or some nausea, out to breathing symptoms and symptoms to do with circulation like low blood pressure, which can leave you feeling faint. And that's anaphylaxis when you have those symptoms. So that's and those symptoms would come on within minutes of eating the food, usually up to at most 2 hours.
And what is a food intolerance?
Yeah, so a food intolerance, look, there are very specific kinds of food intolerance like gluten intolerance, which is celiac disease, and lactose intolerance, and they have very specific meanings. And celiac disease, which is a gluten intolerance or a specific kind of gluten intolerance, involves the immune system, whereas lactose intolerance does not involve the immune system at all. It's a lack of a certain enzyme that helps you break down the sugar in milk. But the word and then there's the other specific way it's used is often infants who have a cow's milk protein intolerance that's usually outgrown. But then intolerance can also be used to mean a whole host of other symptoms that might leave you feeling unwell in some way after you eat certain foods.
We're going to
have apart from those very specific named ones like celiac disease and lactose intolerance, there aren't great diagnostic tests for most other kinds of intolerance.
We're going to come back to food intolerances a little bit later, particularly with Dr. Anne Swain from Royal Prince Alfred Hospital. But let's come to food allergies. Just before I move on, though, anaphylaxis, it's been mentioned a number of times, and obviously we're teaching people in public schools about it, so we're concerned for the safety of children. Could you just give us a little bit more information about what anaphylaxis is and why it's a serious matter that requires community education?
Well, I mean, we want to keep not just children safe, but everyone safe. And anaphylaxis is a life-threatening allergic reaction. And it's life-threatening because it affects body systems that you need to sustain life, like breathing and circulation. And we want people to be able to recognize it and also understand that the first-line treatment for anaphylaxis is adrenaline. You shouldn't go via other things to see if they work first. If you've recognized anaphylaxis, then adrenaline, the medicine adrenaline, which is a hormone our body makes as well, is the first line treatment. And if we know that delayed administration of adrenaline is a risk factor for a poor outcome from anaphylaxis, so that and the worst outcome, as Grace mentioned earlier, is death. It's very rare, but it's something that we feel like we know more about and have some strategies for preventing it, so it really shouldn't happen.
Before I go into more detail, can we stay up in a helicopter?
Sorry.
No. Just to give a sense for our audience of what are some of the primary treatments. You know, we've called this diagnosis and management as a subtext to our webinar today. So are there key treatment or management strategies we need to know about?
For food allergy?
Yes, for food allergy.
Yeah. So traditionally and still, the main treatment is, management strategy is avoidance of your food allergens. And there are some exceptions to that, like, for example, children with milk and egg allergy are often able to tolerate processed forms of those foods, like milk and egg in muffins, for example. But by and large, it's about risk management, so understanding your environment and trying not to let it impinge more than necessary on your quality of life. And avoidance, and then being able to recognize and treat anaphylaxis when it occurs.
And how is it diagnosed?
So I'll get a little bit technical here. Allergies are mediated, or like a part of what causes the symptoms is an antibody that we make called IgE antibody. So they're all, as well as being called immediate type allergies, they're called IgE mediated allergies. And all the tests that we use to diagnose allergy, or maybe I should say both the tests, because there's, the main tests used to diagnose allergy are based on identifying IgE. So you can identify IgE in blood, or you can do a skin prick test, which can cause a hive, and that reflects the IgE. So that's the kind of first line attempt to predict whether someone is food allergic. But actually, I'm just listening to myself and actually backing up one step. The very first test is a really good history of whether the symptoms. Firstly, you need to have eaten the food to be called food allergic. If you haven't ever eaten the food, you can't be diagnosed with a food allergy. You can be what's called sensitized, which means you make that antibody, but you're not allergic unless you've actually eaten the food and had a reaction. And so my recommendation and the guidelines recommend not doing that test unless there's a history that suggests you're allergic to the food. If you haven't ever had any symptoms of allergy to a food and you do the tests, that's called screening. And they're not very accurate when they're used that way. There's a lot of false positives. So first would be history. Then you would do confirmatory testing based on the history. And then if you've got some uncertainty there, then the gold standard test for a food allergy is called an oral food challenge. So getting the person to eat that food under medical supervision in a graded way, starting with a very small dose and stepping up every 15, 20 minutes, and then stopping if they have a reaction, or if they make it to the end of a full serve of that food with no symptoms, then you've actually delabeled the allergy.
I'm going to ask a few more questions of Dr. Lara Ford, but just reminding our audience, you're most welcome to put questions in the Q&A, and our general practitioner, Dr. Lena Safro, will be bringing us your questions a little bit later. Look, I've asked each of our speakers tonight, if our audience remember nothing else, what do you want them to remember? And I might just get you to discuss a couple of those, Dr. Ford, before I move to another panel member. You said if you have a food allergy, it's incredibly important to know how to avoid the food you're allergic to and how to respond if you have a reaction. Now, that sounds obvious, but tell me why that's so critical. You need to know how to avoid the food you're allergic to and how to respond if you have a reaction.
Well, and I would insert in between those recognizing a reaction too.
Okay.
Avoid it, and then if that hasn't been successful, recognize and treat. Sorry, can you repeat your question?
Well, I guess you're saying it's important to recognize a reaction. So that tells me that can be a danger point for someone with an allergy. So how do you help young people and older people? Because your patients go up to 18, and no doubt you're explaining this to some adults as well. How do you teach people to identify a reaction, to recognize it? Why is that so? Is that sometimes hard to do?
Well, I think a lot of people just have been exposed to a lot of myths and haven't had exposure to good education. So when they come and see an allergist, then we always make sure we step through that with them. And there are some really excellent tools for doing that. In fact, Australia has a unified single allergy and anaphylaxis action plan that's published by ASCIA. And anyone who's got kids at school or daycare will have seen them kind of plastered on the wall. And that plan, I feel like it's a great one-page cheat sheet for when people are flustered and in the moment of wondering if they're having a reaction. And it really clearly divides it. Firstly, it divides symptoms into mild to moderate and then severe, which is anaphylaxis. And then within each section, it gives examples of the symptoms. The mild to moderate ones are generally the ones that affect the skin and the gut, even though they can look dramatic. And then the severe ones are the breathing and circulation ones I mentioned before.
And you mentioned ASCIA, that's the Australasian Society of Clinical Immunology and Allergy.
Yes.
And we'll be sending out a link to that website along with the National Allergy Council website and the Allergy and Anaphylaxis Australia website, as well as Allergy Life Australia, Grace spoke about earlier. So I'm just reassuring our audience that there'll be good quality information coming to them. And look, another point you made is that what's really important with young children, and we'll have people with young grandchildren here on this audience, is that you keep the diet as broad as possible. I'm assuming this is right from baby and toddler up. Keep the diet as broad as possible because oral exposure helps maintain tolerance, and that the majority of your work is in fact unpicking the wrong advice because there's been a sort of change in the advice given to parents. So tell us about giving a very young child a diet as broad as possible. Why is that important?
So there's a growing body of evidence to support that having the common food allergens in your diet early, especially if you're at risk, and we can talk about that later, is the best way. And having them in your diet early and then maintaining them in your diet regularly is the best way to minimize your risk of becoming allergic to any of those foods. It's much more common to become allergic to a food you're eating infrequently or not at all than one that you're eating regularly. And that does go against, the pendulum's really swung back and forth. I mean, prior to the 80s, there was the idea of restricting diets was just unheard of. And if people had reactions, they would just try again. And then there was this thought that there might be this, as the food allergy epidemic grew in the 80s and 90s, there was this thought that maybe we could, and people were seeing kids outgrowing some of these allergies, especially the milk and the egg. And so there was the thought that maybe you could bypass that window where they were demonstrating their allergic symptoms by just not feeding them those foods. So that's when the avoidance advice came in. But then this very pivotal trial came out in 2015 showing that it was about peanut allergy, which is often called like the canonical food allergy because it's the one that everyone always studies. But it was a randomized controlled trial, so it was the highest quality of evidence. And it showed that if you took a group of babies before age 1 who were at risk of food allergy and randomized them into a group that you asked to eat peanut very regularly and a group that you asked to avoid peanut, then at age 5, the group that had been avoiding peanut was more than 5 times as likely to be allergic when you fed it to them at age 5 than the group that had been avoiding. And in fact, the design of that study was informed by an observation made about Jewish children in Jerusalem compared with also Ashkenazi Jewish children in London. It was an observational study, which is lower quality of evidence. And so these genetically similar children had vastly different rates of food allergy. The London children were following the avoidance advice, and the Israeli children were eating a common weaning food, were eating bamba, which is a peanut snack, and they had about 1/10 the rate of peanut allergy compared with the London children who were avoiding. But then building on that, they did the randomized study that was published in 2015, and that is really when everything got turned on its head and we started pushing early introduction.
Look, thank you so much, Dr. Ford, and I'll come back to you, but I'd like to welcome now Associate Professor Jennifer Koplin to the screen. And you'll remember that Jennifer is an epidemiologist at the University of Queensland, a scientist and a researcher with a focus on childhood allergic disease. And she's done population studies on prevalence, natural history, causes and consequences of childhood allergic disease. And she's a group leader and a chief investigator in a range of national activities. So welcome to you, Jennifer, and thank you for that beautiful jacaranda in your screen. Why I've come to you is I just noticed that Dr. Ford mentioned the word epidemic, and you're an epidemiologist. Just explain what an epidemiologist is and what you do, please, first.
Yeah, so what we do is really look at the health of populations, and we're interested in understanding things like risk factors for why somebody might develop a disease and somebody else might not. So there's different types of epidemiologists. Some study infectious diseases, so outbreaks, things like COVID. But the type of epidemiology we do is more around, I guess, chronic diseases like allergic disease.
And I know that you also agree that if a person has food allergy, sorry, I beg your pardon, that you now know from more recent research that to reduce the likelihood of developing a food allergy, you need to make sure infants start eating a wide range of foods, including allergy-causing foods. That must be, it's just amazing. There's such a change in the advice. But the word epidemic, do we have an epidemic of food allergies in young people in Australia?
I think, it's probably one of the questions I get asked most often is food allergy increasing and how much? And it's a very hard question to answer because I think some of the background Lara was giving around change in the 80s and 90s, we didn't have a lot of information on food allergy in Australia. We didn't really know how common it was. We know anecdotally people didn't talk about it as much, but that doesn't necessarily mean it wasn't out there and just wasn't being recognised and wasn't being spoken about. We think it's probably become more common. We don't know how much more common. I think it is very common now, I guess I could say. So if you define an epidemic as something that's really common. Yeah, we know that 1 in 10 children at the age of 1 have a food allergy in Australia, which is a very common condition.
Well, that's quite significant, isn't it? I understand that oral immunotherapy is a relatively new treatment. Could you explain what that is and the circumstances in which it may be used?
Probably, I'll stay away from saying anything clinical. I'm not a clinician, so I'd probably defer to someone like Lara to talk a little bit about when it might be used. But the idea behind oral immunotherapy is that it's a way of potentially training the immune system to no longer respond to something that somebody's already allergic to. So the theory is that for some foods, in some cases, you might be able to increase the amount that somebody can eat without a reaction. We know that does work relatively well. What doesn't tend to work as well in the studies that have been done, a lot of them overseas, is it doesn't often mean that somebody it will never have a reaction again. So it doesn't necessarily mean that somebody is completely not food allergic anymore, but it can, in some cases, increase the amount of food somebody can eat without a reaction.
And sorry, I'm just was just trying to think if there was anything more to ask about this new immunological medicine. I'm trying to understand how immunological, that's the word I'm trying to get out, I beg your pardon, immunological mechanism underlie childhood food allergies. Can you explain what an immunological mechanism is and what we know from your research and the research of others about it being sort of an underlying factor? Is it in causation?
Yeah, so I guess I'd talk a little bit more about that sort of development in early childhood. And as Lara was saying, we know now that it's important that children are exposed to a range of foods. And the reason for that, the theory is that exposure trains the immune system in a way not to respond to the foods, to sort of understand that it's something that's not harmful. Whereas if you don't have that early exposure, I can talk a little bit about the dual allergen exposure hypothesis in a second. But if you don't have that early exposure, you're not eating the food, that the immune system then, when it sees it later, might react and sort of see that as harmful. As Lara also mentioned, that involves for the type of food allergy that we mostly study, the production of an IgE antibody, which means the next time you eat the food, you get allergic symptoms.
And there was something you said. Your voice is coming a little bit in and out in terms of the quality, so I might leave you for a moment and our technical man might be able to communicate with you about if we can improve that in some way. But thank you. What I might do now, ladies and gentlemen, before I come to our third panel member, is to come to some questions. So if I could invite Dr. Safro to come onto the screen and we can hear what some of the questions are coming from our audience. Welcome, Lena.
Hello, Julie. Hello, everyone. There's quite a lot of questions coming through. One that keeps repeating is, can a food intolerance wax and wane over time? And secondly, can it be outgrown?
Okay, so we're talking there about food intolerance. We've been mainly talking about allergies so far. I might ask all the panel members to come on screen, if I may, Nat. And I'll come to Dr. Anne Swain, the dietitian, head dietitian in the allergy unit at Royal Prince Alfred Hospital, who focuses particularly in her work on food intolerance. Welcome to you, Dr. Anne Swain. If I can ask you to come on screen. Oh, I know. I have to view you in a different way and I'll be able to see you. Thank you. Would you like to answer that question about food intolerance, please?
Can you just repeat the question again to make sure I've got it?
Yes,
correct?
thank you.
And a few people are asking, can food intolerance or allergy interchangeably peak and wane over time? And is there a chance that one outgrows it through the lifespan?
Do you want to go first, Dan?
What I'd like to say, first of all, it's very, very important, and that's what Lara was pointing out as well, that we understand the difference between a food allergy and food intolerance, because a food allergy is an immune-related reaction, and a food intolerance, and I'm just going to read something to you, It's different to an allergy reaction. It doesn't involve the immune system at all. They're triggered by food chemicals that are found in a range of foods, and they cause reactions by irritating nerve endings in different parts of the body, similar to the way that certain drugs give us side effects. So when I'm answering the question, does it wax and wane? I think we should ask Lara that question about food allergies. But when it comes to food intolerances, people who are sensitive can have variable tolerance to that. And their tolerance can change with illness, with stress, with hormones when they're older. And the dose that you take is also very important when it comes to intolerance. With allergy, Lara can talk about this more, but with allergy, you tend to find that most children grow out of their egg and milk allergies by the later teenagehood, whereas nut and fish and seafood allergies, they're the ones that tend to persist through life. And that's why it's really, really important, as I was saying, that children get exposed to these things early in life in small amounts on a regular basis, so that their immune system gets to know this is really not a dangerous thing. This is a friend, not a foe.
Look, thank
Lara,
you.
would you like to comment a little more?
Yes, thank you. Dr. Ford. If you could turn on your mic, yeah.
Hi, I'm back. So food allergy, I agree with what Anne says about the the allergens that it's common to outgrow and the ones that it's common to persist. One common question I get is whether allergies get worse and worse with each exposure, and that relates to that aspect of the question that Lena asked about waxing and waning. So yeah, firstly, I agree that milk and egg are commonly outgrown. There are some people who retain those allergies into adulthood, and the nut and seafood ones are much less commonly outgrown. And in fact, seafood allergies I often see come on later, like in my primary school aged and adolescent patients. But then with the waxing and waning, I think it's important that people understand that it's not just the food that you're allergic to, and you can't be anaphylactic to a food in like globally. You can be at risk of anaphylaxis. And in fact, everyone who has an IgE mediated or immediate type allergy is at risk of anaphylaxis. But the severity of any individual reaction depends not just on what the food is, but on a whole host of cofactors. And that includes things like how much of it did they eat, things like exercise, drinking alcohol, having your period, being sleep deprived, they can all lower your threshold for reacting. Having an intercurrent illness like a cold. So you might, if you could, do this experiment where you had the same person on a good day, which is actually, by the way, what we try to do on a food challenge day. We would turn someone around and send them home if they come in for their food challenge in the middle of an asthma attack or unwell. But yeah, if you have them on a good day, when they're sitting still in food challenge clinic, or on a day when they've got a bit of a cold and they're just playing and they're playing their usual soccer game and they haven't slept well, then the same amount of food might cause a much worse reaction when all those cofactors are present than when they're not. So reactions can wax and wane, and most people who have an episode of anaphylaxis have had mild to moderate reactions before. So you shouldn't. I'm very much in favor. I think the biggest problem that food allergy causes is the anxiety in the family. So I'm not trying to scare people, but everyone who has that kind of allergic reaction, immediate type allergy, should know how to recognize and treat anaphylaxis. They shouldn't be lulled into a sense of security that, oh, I've only ever had hives, so that's all that will ever happen to me. Because given the right storm of circumstances, they could have anaphylaxis. But on the other hand, just because you've had a bad reaction, in fact, many people's worst reaction is their first reaction before they really understand what's going on and how to manage situations. So just because you've had a really bad reaction doesn't mean you need to be scared and like never go out of your house again and, you know, eat the same 3 foods. You know, there's variation from event to event.
If I could just make a comment, from the complexity of the interaction between other factors, whether they be health factors or even social context, it sounds like having a relationship with an appropriate, well-informed professional on an ongoing basis is quite very important in relation to allergies. And I'm going to come to you in a moment, Anne, for a bit more on food intolerances. But just staying with you, Lara Ford, you really do need to have the family and the individual need a relationship with a well-informed clinician. Is that right?
I agree. I think it's important. And even if you're not doing anything high tech, sometimes when I see a patient I haven't seen for a couple of years, I say, what's been happening with you since I last saw you? And if there's been a few events where, you know, they've had reactions, then we can sometimes identify patterns that you know, addressing could help reduce the risk of reactions in the future. We can debrief about how they've managed those reactions and help improve their anaphylaxis education. So I agree that it's really important to have an ongoing relationship with your allergist. And there are other reasons too, like that there are hopefully new treatments coming down the pipeline that if you have that ongoing relationship, you kind of are in the loop about.
I just want to come to you, Anne Swain, for a moment, just to clarify a little bit more about food intolerance, separate from allergy, because one of the things you've said is that a food allergy reaction tends to be immediate and can be serious quickly, as we've been hearing, whereas food intolerance reactions may occur over a longer period of time. For example, when the person has eaten a lot of the food and there will be a cumulative effect, but it can be a more delayed reaction and less severe. Is that generalisation accurate?
That is accurate. What you find with the food intolerance, different people have a level of tolerance to the chemicals in food, and it very much depends on how much of the food they ate, over what period of time, and also the symptoms. So when we're looking at food intolerance, the typical symptoms that people have are usually symptoms that give them a lot of discomfort, but they're not necessarily life-threatening like they are with a food allergy. So the symptoms would be things like stomach and bowel problems, and things like nausea, headache, recurrent hives and swellings. You can also find that people can get reflux, and that can be either with heartburn or with throat irritation and sinus troubles. And it can also cause children to become irritable and restless, and it can often exacerbate their behaviour in those children with ADHD.
And again, just a couple of quick facts here. I understand there's no reliable skin or blood test to diagnose a food intolerance. And you engage in a diagnosis by dietary elimination and challenge, and that you need a systematic approach for tracking down the cause of the particular food intolerance. But it may be that there are a range of foods that an individual has an intolerance to because of what you call chemicals in the food. So it's not about a specific thing like a nut or a particular kind of fish. It's a more general, is that correct?
That's absolutely correct. And that's where patients or people who come to see a dietitian or a doctor to ask about food intolerance, they'll often come in giving a list of foods. And when they're asked, do you get a reaction to them all the time? They'll say, oh, no, sometimes I do, sometimes I don't. And a typical one would be chocolate. Sometimes chocolate gives me a headache and sometimes it doesn't. Or they'll say berries, strawberries or blueberries or tomato or orange. Sometimes it'll give me a stomach ache and sometimes it won't. And if you have in your mind that an allergy, that if you eat the food or consume the food, you get symptoms very quickly, then if you put that same idea with intolerance, it doesn't seem to measure up. So intolerance is very much about the dose and how much you have over time. And so for some people, it's if they might get away with a strawberry or two, but if they sit and eat a whole punnet of strawberries or a whole punnet of blueberries, which is, seen as being a very healthy snack, that may be just too much in a short period of time and for their system, and then they'll get symptoms.
Look, thank you. I want to come back to questions, but Dr. Ford, did you want to comment at all in relation to what's been said, or will we move to another question?
No, I'm happy to move to another question. I think that that summary about there not being a good diagnostic test for these intolerances is really important to recognise, and it can be very hard to tease apart.
I was just thinking that because it's so important, isn't it, to have I'll just ask what's in my mind, at times a medical assessment, because some of those physical and mental conditions may be related to another underlying health condition altogether.
That's the thing that's hard to tease apart, that I think there are so many things that can cause, say, belly symptoms and headache and runny nose. So, for example, environmental allergies can cause itchy throat and runny nose and mucus production. And, a common myth is that milk is associated with mucus, and there's scientific papers that disprove that. So I think there's a risk if people are chasing, are very blinkered about wanting. It's natural to want to be able to control symptoms that are disturbing you, and food is one of those things you can control. And so people often get quite fixated on identifying a food cause for their symptoms, and there may not be one. So one of the most important things that I tell people about elimination diets, if they're insistent on going on them, and I hardly ever recommend them, is that if they do go on them, they should make it for a defined period of time, no more than 2 weeks. And if the symptoms don't improve, then they need to put it aside and look for other causes, and not continue with that diet, because that can contribute to that narrowing of the diet that I worry so much about in little children.
Can I add to that, Lara? I think that was a very, very good comment. The first thing I would say is if somebody thinks that food may have a role, and they may or may not be correct, they need to go and see their GP. They need to go and see their doctor and discuss it with them, because you also want to make sure that before you go down the food line, that you don't have some other serious condition going on, that you don't have a true food allergy, that you don't have some other nasty diagnosis that is being overlooked because you're wanting to follow down the food track. So I would always suggest before you ever start changing the diet. Similarly, with people who think they might have celiac disease, it's very common for them to take the gluten in their diet out of the diet before they're actually tested. Then they improve, and then in order to be followed up correctly, they need to put wheat or gluten back into their diet so that they can have the tests done for the antibodies, and also so they can have a small bowel biopsy to be properly diagnosed. So the first thing is go to your doctor with your history and go through that with them. Then you can start to look down the line of food. But again, it is better to go and see somebody who understands the area rather than starting to take one food out of after another, because it's very common to say, I've eaten this food and I've got these symptoms, therefore they must be connected. Whereas it may be the build-up of a number of different foods and you're just blaming the last one. And that's why I like the example of chocolate. Chocolate's the last one. Oh, I got my headache. Oh, well, it must be chocolate. Whereas there might be a whole lot of the reasons, like Lara was saying. There's your hormones, there's stress, there's illness, a whole lot of other factors that really need to be taken into account before in children or adults you change the diet.
Look, thank you. What I'm going to do now, and Jennifer Koplin, I'm going to come to you to ask for some current interesting areas of research in just a moment, but I'd like us to slightly more, with some efficiency, get through a number of questions. So, Dr. Safro, can we have more audience questions, please?
Sure. So there are quite a few questions here about peanut allergy and sesame seed allergy. And people are asking, what can someone do to reduce or prevent or to reduce the severity of their reactions?
Dr. Ford, please.
Okay. So I've got a little eye on the questions too. And I think people are really asking whether there's a treatment. I mean, the obvious advice about avoidance and the risk, risk reduction about not eating it. We've already talked about that. But and the subject of food oral immunotherapy came up before, and I wonder if that's a bit what people are asking about. So oral immunotherapy and other forms of food immunotherapy involve gradual exposure to the food itself. So it's trying to train the immune system out of making a reaction. Now, there's a buildup of evidence showing that there's one outcome you can achieve is called desensitization, which means as long as you're having your daily dose of the food allergen, you can tolerate a little bit of that food, like Jennifer was saying before. And there's a reasonably high rate of desensitization that you can achieve. But then you stop taking it and then you eat the food again and your symptoms come back. What the holy grail is this outcome called sustained unresponsiveness or remission. We don't like to call it cure because no one's studied it out for that long. But what sustained unresponsiveness means is that you can take a break of maybe 6-8 weeks but we don't like people to risk it that long, but you don't have to be eating it every day. It's like free. We want people who have achieved that state still need to eat the food regularly, but it can be incorporated into a regular part of their diet. And what the recent research shows is that it's far, far, far more common to achieve that sustained unresponsiveness outcome when you start it in infants and toddlers and preschoolers. It's very difficult to achieve that in adolescents and adults. And the process of getting there is the same for both desensitization and sustained unresponsiveness. It's just that daily eating for a couple of years, if you're trying to get to the sustained unresponsiveness outcome, no one's achieved it in really short amounts of time. So you're talking about taking something you know you're allergic to every day, and every dose carries a small risk of a reaction if some of those cofactors that I talked about come into play. So it's kind of not for the faint-hearted. It needs a really big discussion, and it actually is in its real infancy in Australia at the moment. It's not something that is being done a lot yet because of all those problems. Most of the time people feel that the downsides, the quality of life issues around having a rest period after your daily dose, so you don't have that exercise cofactor, and being really rigid about taking it every day with the low chance of success, it doesn't always justify all that effort.
Yeah. Can I ask you, have you ever done it with a patient?
Look, yes, I've done it a lot in the study setting. I do a lot of research. And in fact, we're doing a study on infants at the moment who have come to us before they're 1-year-old with an immediate type peanut allergy. And there's a national program that's been rolled out across 10 pediatric centres where we're have a very structured program where we feed them peanut every day. We're going to do it for 2 years. No one's hit the 2-year mark yet. Then we're going to stop for 8 weeks, do a food challenge and see if they can tolerate peanut.
And just clarify again what a food challenge means in that example.
Yeah, it's a medically supervised food challenge. It's a graded feeding. Every 15 minutes, you're giving a bigger and bigger dose over about 2 hours, so about 6-8 doses. And then you watch them for another 2 hours because we think that immediate type reactions usually present within 2 hours at the very most. So it's like a 4-hour procedure, and And if along the way they get any symptoms, that the symptoms we were talking about before, then you stop the feeding, you treat the symptoms. And
look, thank you very much. Jennifer Koplin, I'm very aware that I'm not bringing you in. We're on such clinical questions, but would you like to comment on anything that we've said so far?
I guess one thing that was mentioned quite a while ago when we were talking about people outgrowing their food allergies, and peanut being less likely for somebody to outgrow. I absolutely agree. So it's much less common, but I would say that in some of our studies, kids who are peanut allergic at age 1, about 30% of them actually outgrow their peanut allergy. So even for something like peanut, it's not impossible that your allergy will resolve. There are also later onset allergies, so it's balanced a little bit that some children grow out of their peanut allergy and other children might develop their peanut allergy a little bit later in life. I think that was sort of the one thing that I think I could probably add in terms of research.
And has there been any other research you're aware of where children are able to with particular foods, lose or reduce their allergic reaction so that it's more safe?
In terms of, I guess what Lara was talking about with the oral immunotherapy is there is absolutely that, as she was saying, that works in a lot of cases, and particularly for the young kids.
But with all different sorts of food, not just with peanut.
Yeah, so I guess peanut is one of the better studied. We know for egg and milk that because most children grow out of it anyway, naturally, there is some research looking at whether or not you can make that happen more quickly by, in egg and milk, it's sort of giving low doses but also well-cooked egg. So there's some research internationally and a little bit of work in Australia as well, looking at whether or not using something that they call an egg ladder or a milk ladder, so gradually increasing the amount of the food that you can eat, and I guess a really, really cooked food to start with and then less cooked, and that's because there are, for egg and milk, a lot of children who react to a raw or less cooked form can tolerate a much more cooked form. I think Lara alluded to that earlier, when I guess avoidance in most cases for most people, but there are some scenarios where you can tolerate small amounts. And so the idea is, again, a bit like the oral immunotherapy for peanut, that getting that into the diet might increase the likelihood that you outgrow it and outgrow it quicker.
In the health world, a lot of people talk about personalised medicine. This must be the ultimate area of personalised medicine. You have to know the individual nuances of each patient. It's amazing. Lena, we'll come back to you for some more questions, please.
Somebody wants to know if there is a link between food allergies and asthma.
Dr. Ford, can I come to you first?
You could, but I feel like I'm happy to talk about it, but I feel like I've been hogging the spotlight, and Jennifer's also got some interesting things to say on that.
Okay, thank you. Jennifer Koplin, thank you.
Yeah, so I guess the short answer to that is yes. So people who have a food allergy are more likely to have other allergic diseases. So in early life, they're more likely to have eczema. In fact, it's sort of the other way around. Eczema is usually something that develops first. Children with eczema are more likely to go on to have a food allergy, and then children with a food allergy are more likely to go on to have allergic rhinitis in later life and asthma as well. Not everyone with a food allergy will have asthma. This is, I guess, the research I do is at a population level. So in a big picture, it doesn't mean if you have a food allergy, you must have asthma, but there is certainly an increased risk.
And is there any understanding of why?
Yeah, it's not terribly well understood, I'd say. I think there was another question in the chat around allergies being genetic. And so I guess that one of the theories is there's an underlying genetic predisposition to allergic disease in general, and that can include a range of allergic diseases, not just food allergies.
Thank you. Alina, another question, please.
Sure. There's an interesting one. How does one go about minimizing a risk of eating disorders for children that are growing up with a range of food intolerances?
Well, that's an interesting question. Who would like to go first? Is there someone who immediately has something to say, or will I just ask each of you? It's a complex. Can I come to you, Lara Ford? Often we do come to a doctor a fair bit on these sessions. It's the nature of the game. Yeah.
Okay. So how do you minimize the risk of eating disorders in a child with food allergy? So I think I alluded to it earlier, that it's very, very common for children and their families with food allergy to have mental health issues around it as well, like anxiety and often it's not a generalized anxiety. It's often really specific to the food. So I think getting your allied health buddies involved is critical, like having a good dietitian. So to take some of the fear out of it, to explain how to read labels and effectively avoid your allergens is one thing. How to substitute so you're not missing out nutritionally. On things like calcium. And then and also understanding knowledge is power, like understanding better already reduces anxiety. But then some people benefit from a psychologist who understands food allergy. And I think just the parents and caregivers understanding themselves, how they're projecting their feelings onto their children is also really critical. And those are a few of my thoughts, and if you want to see what others have to say, go for it.
Yes, thank you. Anne Swain, your thoughts as a dietitian at RPA, if you've just joined us on the audience.
The other thing that I would say is, like Lara said, seeing some health professionals, like with the dietitian, talking about substitutes, not just when they're cooking at home, but what do I do when I'm out? What do I do when I go to a birthday party? How can my child feel like they're part of the party? And often I'll say things like, why don't you, first of all, speak to the parent who's putting on the party? They're often very understanding, but also take along some food that is party type food for your child, but take along enough it's for everyone, and make sure there's plenty, because you'll often find the other children go, oh, that's interesting. Oh, they're eating it. Maybe I can eat it as well. So it's making them feel included and getting the family on board, not just the immediate family, but the more extended family as well, grandparents and aunts and uncles, so that if they've got an egg allergy and they go to somebody's place and they say, oh, we're having pavlova for dessert, and the child's egg allergic, there's not this, oh my goodness, there's going to be egg in everything. It's much more being aware and preempting a lot of that. Making them feel like they're the same as other children, and making them feel safe.
Can I ask you, Jennifer Koplin, are you any comments you'd like to make on this issue?
I don't have a lot to add, except that, I guess it is also an area of interest for research, the link between food allergies and eating disorders. And one of our PhD students at the moment is looking at the link between food allergies and a relatively new type of eating disorder, which is known as Alfred, so avoidant restrictive food intake disorder. And so I think it's really an emerging area. I think understanding the links and understanding how better to hopefully prevent the development in children with food allergy is
unfortunately, we've lost you again. Your sound is a bit difficult, but thank you for that contribution. I suppose the one comment I'd like to make is that often in the world of health, there is not a great deal of attention to the social context of the individual patient and the provision of psychological support. I often think a lot of doctors and nurses would like to have someone to refer an individual or the family to, but they're not always members of the multidisciplinary team. And I can imagine, even short of diagnosable eating disorders, just the general anxiety within a family, particularly if there's an acute threat of anaphylaxis, it must be very hard to keep everybody emotionally stable and not let the child become very anxious. Is that something you deal with? I'll go to Anne Swain first. Is that something you consciously work with your families?
It most definitely is. And it's having, as I said before, it comes back often to having a very good GP who can sit with them and listen to the anxiety as it first happens. It's also having a very good allergist, but they're very busy as well. And it's having a network of other health workers that they can go to and talk about their anxieties, be it the dietitian, be it the psychologist, etc., to make sure that not just the child, but the family as a whole managing this well. Because as Lara was saying, often the parents are very anxious, and then the children also pick up some of that anxiety as well.
Any comment, Dr. Ford?
Yeah, it's very difficult. I mean, I only work in the public hospital system, and we are incredibly under-resourced. We have a tiny fraction of a dietitian and no psychologist. And I think it's a huge area of need. And as I alluded to before, I think in some ways more than the medical risks of food allergy, the bigger impact on people's lives is quality of lives is mental health, and just I think the restrictions that people place on themselves are due to perceived risk rather than real risk, or sometimes the degree of restriction outweighs the real risk. I'm not saying people should be cavalier, but I see situations where, for example, people think that merely being in the presence of their food allergen can cause a dangerous reaction, which isn't true. You have to eat the food to have a true reaction. So that's an example of a myth that often requires unpicking.
Look, thank you. Dr. Safro, another question from our audience, please.
Sure. On the same note, but now looking at adults, can you give some tips, practical tips for people who want to eat out, who know that they've got food allergies?
And we might say food allergies and food intolerances for this purpose, if that's okay. Can I come to you, Dr. Anne Swain, first, our dietitian? Your tips for going out, my God. I look at menus. When you go to a place like New York, menus are like detailed diet analysis. Do you know what I mean? It's different culturally in different societies, I think. But your observations and tips.
My observation would also be when they're eating out, if you know what you're sensitized, what you have an allergy to, or what you have an intolerance to, then choose restaurants that are going to be able to serve you meals that are less likely, in the case of allergy, to be contaminated. So if you've got a seafood allergy and everybody says to you, let's get together at a seafood restaurant, then your risks are probably quite high with cross-contamination. So then you would say, let's go to a steak place or a hotel where we know that they're going to serve more regular meals. So it's knowing what you're allergic to or knowing what you're intolerant to, and then choosing accordingly. Another example would be, if you know that MSG, lots of MSG really upsets you, then choose restaurants that are going to give you more plain food, that there's less sauces, etc., that might contain those sort of ingredients.
Lara Ford, your practical tips. Anything else?
I have quite a few practical tips on this issue. I would say it's extremely important not to make assumptions when you're reading a menu about what the food contains. You should always declare your food allergies to the food server and explain why. You say, I or my child am allergic to these foods, and I can have a serious allergic reaction like anaphylaxis if I eat them. Can I check that these items I'm considering ordering, that they don't contain my food allergens? And sometimes that'll involve a conversation with the chef, and that's fine. So I think people often assume from reading the menu what a food's going to contain, and they might be wrong. And so that's one tip. Just be really upfront in declaring your allergens every single time. They might change the recipe. You just have to do it every time. Buffets are like a really bad idea for people with food allergies. Obviously, only if the buffet contains your food allergens. But you know, the problem is that the institution isn't as in control over people putting, you know, serving implements in the wrong dish and that kind of thing. So I get a lot of seafood reactions at buffets. So. And then there's a lot of really great resources on the National Allergy Council and ASCIA websites about courses that food servers can do. Often, I mean, some of the people in the audience might have grandchildren who are in food service. There's a food allergy aware course that you can do on the ASCIA website where food servers also become aware of allergies.
And I'll just say again that ASCIA is the Australasian Society of Clinical Immunology and Allergy, and we'll be sending a link out. I just want to make a comment, I suppose. I know all of you are involved in education in one way or other. What strikes me is I've seen people in restaurants when I'm out with a group trying to talk to someone serving in detail about their needs, and they can often be treated as if they're sort of neurotic fuss budgets, if I could put it bluntly. And can we do more in this world that's overwhelmed with information to communicate, particularly in the hospitality industry, that this can be a life-threatening issue, and it's not being nitpicking, it's a health issue. Do you feel we're doing enough, I guess, is the question. Anne Swain, what are your thoughts?
It's an interesting question you ask. And I will talk about celiac disease and having to avoid gluten completely. In this day and age, there's a lot of places that they say the food is gluten-free. And that can have varying levels of what they mean by gluten-free. For somebody with celiac disease, they need to treat the gluten just like you would a food allergen, so completely avoid it. The problem is that a lot of people nowadays have got a gluten intolerance, and so they will say, I can't eat gluten, and they will be very fussy about the main meal. And then when it comes to the dessert, they'll go, oh, no, I can have a bit of chocolate cake. That'll be okay. And that's when some of the restaurants also get confused. So you've got those that have got genuine food allergies or a genuine gluten reactivity, which is an immune response with celiac disease. And then you've got those that may get a bit of an upset tummy if they get too much of gluten in their diet. And unfortunately, for the restaurateur or for the young girls or guys serving you at the table, they often can't tell the difference. And so that's sometimes where they're not being laissez-faire. They're just going, oh, yes, this is another person who wants a gluten-free meal. And like Lara was saying, if you've got a wheat allergy or an egg or a milk or a nut allergy, it's really good to point out to them, or you've got celiac disease, you can even take some of the anaphylaxis plan with you just to point out to them, I'm asking about this because if you're not careful and I get some of these, the reactions can be quite marked. And so I think I'm on both sides here, where the industry's trying to supply meals, but there's a chain of people as well. You speak to the person serving you, they get out into the kitchen, there may be somebody plating, and then there's somebody preparing the meals. And spoons go from one thing to the next. And so it's really important, like Lara said, that you get across the message that if I've got an allergy or I've got celiac disease, this can have serious repercussions. And so I'm not doing this to be fussy. I'm doing this to be safe.
Look,
and I think
you.
That's very important to get across.
Yes, thank you.
And I might just add that because another way you could say, oh, does this meal have wheat in it, and leave it at that. And that's not really enough if you're truly allergic. But as you say, it doesn't get around that fuss pot impression problem, but Anne's already talked about that. But I would say that the fact that there are more people who are self-diagnosing them with intolerances, and just that there's more demand for foods that cater to different diets also has some benefits for truly allergic people. Like, I don't feel very old, maybe I am, but even over the time that I've been practicing, I've seen like a much bigger range of options for packaged food for people who truly are wheat and milk allergic. And maybe some of that's helped by the kind of, I don't know, the people for whom it's a fad, because they're helping create that demand. So
I'll just share a quick anecdote, but I'm a Christian who goes to church, and it's now common with, the host when you're taking communion, that they'll offer you a gluten-free option, which I can't, it's kind of stunning when you think about it. But
Julie, I'm similar to you. I go to church as well, and I actually prepare the host. And so I prepare a gluten-containing one. And since COVID, we put them in little plastic bags so people are not touching. And then we have a gluten-free one for the same reason. And I'm very conscious, like what Lara's saying, of when I make it gluten-free, it is truly gluten-free, not just low gluten, because I want to make sure that if somebody is in the congregation and has celiac disease, that they're not misled that, oh, yes, it's sort of gluten-free.
I'm going to come, we've only got 10 minutes left, and I'm going to come back to you, Lena, for more questions. I just want to give poor Jennifer Koplin, who's got a difficult line, our science researcher and epidemiologist. I'd love to hear from you about an area of research you're currently involved in that you're just really excited because you think it has the potential to assist people with food allergies or food intolerance, something that's of interest to you.
Yeah, I hope you can hear me now. I'm sorry, I'm not sure what's happening with the internet here. So one of the things that I've been looking at recently that's been a really interesting area of research has been looking at what's happened in Australia after we introduced the new guidelines recommending that people start eating a whole range of foods, and particularly those common allergy-causing foods in early life. And what we've seen, which I think we're a bit surprised about, has been that there was really high uptake. So despite the fact that that's a big change from what was recommended maybe 20 or 30 years ago, people really did get on board. We did see a lot of people starting to give peanut products to their kids in the first year of life. And we're starting to see in some of the research a little bit of a decrease in peanut allergy and also in some work that's going on at the moment in egg allergy as well. So I think, to me, it's really exciting that some of the things around preventing allergy might be starting to reduce this epidemic of food allergy in Australia and also around the world.
And do we know why there's such a significant increase? I mean, is it something to do with the nature of people talk about a lot of food that's unhealthy that's causing the obesity epidemic. Are there any sort of broad theories as to why this increase is occurring?
Yeah, there's a lot of theories. It's, again, one of the most common questions that we get asked. And there's a few things that we know. So the increase does seem to be largely in the Western world. So there are studies in Asian countries, in Singapore and other countries that are showing that food allergy is still not very common there. So maybe it is something to do with the diet. We know, as I sort of mentioned earlier, that it's also linked to things like eczema, which are also very common in Australia and also in other Western countries. One of the other really interesting things that we see is that the people who are the most likely to develop a food allergy in Australia are actually children who have parents who've moved to Australia from Asia. So the parents themselves have very little allergy. They often say no one in the family has an allergy. We've never really heard about it. The kids have about three times more likely to get a food allergy than than children of parents who are born in Australia. So it's something genetic and environmental that must be playing a role there.
Absolutely fascinating. Lara Ford, I just wanted to ask you about eczema, because when we spoke before tonight, you said it's very important for people to know don't put food on children's skin. And I was a bit surprised when you said it, because I've watched toddlers eat and that's a very hard thing to avoid. But you mean something different. Can you just quickly explain that?
Yes, thank you so much for coming back to that, Julie. I think that's one of the big headline messages that we're trying to get out in terms of food allergy prevention is we think that your skin is supposed to be a barrier. And if you've got eczema, then there's little mini defects in that barrier. And so when you put anything on the skin, the immune cells in the skin will inspect what's coming through and go, "Ooh, here's an invader." And if it's something that takes it back to the lymph nodes, says, "Do we know what this is?" And especially if your immune system doesn't know that protein, then it'll
we're having some trouble with
go,
you too.
"Oh, this must be dangerous. Let's mount a defense to this." Oh no. Let's mount a defense to this item. And we think that's how, whereas if you encounter a foreign protein through your gastrointestinal tract as food, then that's the way that your immune system is expecting to see foreign proteins. And there's all of these immunological co-signals that help make you tolerant of that. So we want food to be introduced to the immune system via the gut and not via skin.
And what are the sort of products that have food in them? Because you're not just meaning putting a bit of,
Exactly. So there's this, so some of the examples would be things like oatmeal products for skin, or fancy things. Oh, someone today was saying in our clinical meeting, the patient came in asking for a very allergic child came in asking for a Brazil nut skin test because they wanted to use Sol de Janeiro. I'm like, what is Sol de Janeiro? It's a cream that's apparently front and center at Mecca at the moment, and it's got Brazil nut in it. So and mugu and goat's milk products and people think that putting food on all of that things with ingredients they're familiar with and nice short syllables are like natural and better than the long petrochemical names that you would see in Vaseline or something. But actually we love petrochemicals and like just really bland, boring Vaseline is maybe one of the best things that you can use because you don't run that risk of confusing your immune system. Yeah, so things like mugu, papaya lip balm, almond oil, avocado oil, coconut oil. People love putting coconut oil and coconut containing things. And we think that is how some people get sensitized or become allergic to foods.
I'm so glad I remembered to say that because that's extraordinary. Can we have one quick question? We'll have to have a very sharp answer. Lena, do you have another question?
Yes, of course. Of course, lots of questions here, Julie. But one that I think everyone wants to know about is what are the links between food intolerances such as sugar, flour, starch, and ADHD?
Oh, my goodness. Anne, do you want a quick response? And then I will come to Dr. Ford again. Thank you.
Okay. When we're looking at sugar, sugar is usually not it's the item that they see in a range of foods that they see as the common denominator. None of us ever sit down and eat a bowl of white sugar and go, oh, wow, this is fantastic. We eat it as cakes, biscuits, lollies, etc. And it's all the other additives, the colors, the preservatives, and some of the artificial flavors in those things that can exacerbate behavior in sensitive children, not in all children. And so when they're talking about sugar, they're really talking about a range of sweet foods. But as I said, it's the other ingredients that are likely to be a problem, not sugar.
Thank you. And Dr. Ford, your thoughts? Yeah, there's no good direct evidence for those things. I mean, I've met patients with these questions and I have a lot of sympathy for them. And I think that in the same I think there's like a grain of truth there. Like there's, for example, the kids with ADHD, when they're sitting an important exam at school, will get a room to themselves without distractions, and you try and optimize their environment. And in the same way, if you've got a kid who's easily put off by a little bit of, discomfort or something that might not, set off the next kid, then maybe, feeling a bit hyped up or uncomfortable in some way might unmask something that's already there, but it's not causing the ADHD at all. This is sugar, flour, and starches are just normal foods, as Anne said, and so they're not causing ADHD.
Okay, thank you. Maybe one more quick one, Lena. It will be devils, eh? Take it up to the top of the clock.
I could have asked it earlier, actually, but we all know the common
So we've just lost your voice for some reason.
symptoms of an allergy, the reaction symptoms, such as hives.
Could you just start again? There was a delay in your voice. Yes.
Sure. So we know about the common symptoms of reaction, allergic reaction to foods. Somebody wants to know if epilepsy could be one of them.
No, that's a really easy one to answer.
Julie asked for a quick one.
Cannot cause epilepsy.
Right.
Okay, thank you. That was a fabulously brief answer as we come to the end of our session. Look, I just want to sincerely thank Dr. Anne Swain, a dietitian from Royal Prince Alfred Hospital, Associate Professor Jennifer Koplin, our epidemiologist from the University of Queensland, and apologies I couldn't bring you in more often, but we had some technical issues there. And thank you to Dr. Lara Ford, our Senior Staff Specialist in Paediatric Allergy and Immunology at the Children's Hospital at Westmead.